Any questions on last material from Tuesday? STDs, HIV, right? So you're gonna tell all your patients that the only way to prevent STDs is abstinence, right? I'm just kidding. No, don't do that. That's not reasonable. Anywho, all right. So we're gonna continue on with our talk. We're gonna start with nephrology. Now, this stuff is very important. I'm not kidneying around. Yes. Sorry. That's my really bad jokes. All right. For this section. Anyway, all right. So we're gonna start with acute kidney injury. We're talking about this specifically because so many medications can be involved with acute kidney injuries. We'll talk about chronic kidney disease a little bit later, and then some of the kind of the secondary effects of that and how we can treat that with some medications. But a large number of the cases of acute kidney injury you guys will be dealing with will be medication related, at least in some degree. So we'll kind of look at the different types and how this can be involved. Ways we can hopefully prevent it in some cases. But how would you be looking at, or how would you kind of assess whether or not a patient's having acute kidney injury? Most frequently, you're looking at your serum creatinine. It should be going up. You're looking at your BUN as well, and then your urine output. Okay. Do you guys remember what I kind of said was like a normal kind of urine output? You know, like for kids? Usually 1 ml per kilogram per hour. Usually for kids, usually a pretty good urine output. Somewhere between like 0.5 and 1 for adults is usually pretty good urine output. So again, always make sure you're looking at your urine output in conjunction with your serum creatinine and BUN, because very frequently you may see that being kind of the first thing that takes a hit, because we'll talk about serum creatinine and how that kind of has a little bit of a lag time with it before you may see any changes there. But we do know patients who develop acute kidney injury are at risk for more morbidity and mortality, and it's really important that we kind of recognize when it's occurring, because we don't really have any good way to reverse it necessarily, but we can hopefully stop the offending agent or whatever the disease process is that's causing it to occur, and hopefully stop that and allow the patient to kind of recover naturally if possible. So other things we would like to do is to make sure we're monitoring their hemodynamic status and maintaining that appropriately. We'd like to minimize our nephrotoxins. Do you guys remember any nephrotoxins we talked about previously? Not tetracyclines. Lithium can, it can certainly have some issues with some, it can cause some acute kidney injury. Cisplatin, that can be a good one. It's causing more like kind of bladder toxicity. Myoglobin is bad. We don't have any pharmaceutical preparations of that, but so think about things like aminoglycosides. Think about things like amphotericin B. You use that for a lot of really bad fungal infections. We'll talk about more of those at length, but so certainly lots of different medications that can be involved with this. NSAIDs can cause acute kidney injury. ACE inhibitors can cause acute kidney injury. Lots of different things can be involved with this, but also be monitoring their blood pressure. Would you expect their blood pressure to be going up or down? Probably up, but it kind of depends on what the disease process is, right? If they're septic and they're hypoperfusing the kidneys, causing their acute kidney injury, and they're probably hypotensive. So it could be either way. You may need to monitor it one way or the other. But fluid balance is going to be really important, whether or not we need to make sure we're tanking them up, or maybe they're losing too much fluids, or if we need to restrict fluids at all. And then look at their electrolyte homeostasis. Very frequently, this is going to become a secondary problem to acute kidney injury when you're seeing their potassium starting to go up, their sodium comes out of whack. We'll talk much more about that a little bit later on. So there's a couple of different ways you can assess acute kidney injury. There's things like the rifle criteria, where basically they're looking at changes in serum creatinine and then the subsequent GFR calculation that you're doing. You guys remember what that kind of the most common GFR calculation we do for adults is? It's like Cockcroft-Gault equation. Remember that? It takes into account patients' serum creatinine, their age, and their weight, using all of that in order to come up with the serum creatinine, and then or come up with the GFR. Remember how there's like a conversion where you do 0.85 multiply that, but for females, so that way you take into account that you usually have less muscle mass on average than the male patients do. But basically, you're looking at serum creatinine, looking at their GFR, and then urine output as well, and kind of assessing based on the degree and change what type of a kidney injury they're having. So, for instance, if you're having, by this criteria, if you have a serum creatinine increase of 3 times or higher, or GFR decrease of greater than 75%, or if you're anuric, that would be considered renal failure, right? So that would be a very bad thing, but certainly there's degrees of this. Usually if you see a patient's serum creatinine jump 1.5 times or have a 50% increase, that should be a big warning sign to you. It should be something's going on here. We need to assess and see if there's any nephrotoxins or see if there's some other process happening here that we can look at. So again, 50% jump in serum creatinine is very important to look for there. And then, there's other types of criteria, such as acute kidney injury network criteria. Again, very similar. They just might have a little bit of different kind of cut points for what they consider to be kidney injury, but looking all at very similar things. So, how, kind of where are we seeing acute kidney injury occurring? So there's kind of community acquired, there's hospital acquired, and then kind of more specifically, kind of like ICU acquired acute kidney injury. And so looking at how frequently it occurs in your patients, obviously, the sicker your patient is, the more likely they are to develop an acute kidney injury, right? Especially those ICU patients who are sick, they have, pneumonias or other types of infections, they're getting hypovolemic, all of that can precipitate acute kidney injury. Lots of different things are happening there. Usually, as you get more of a sick patient in higher stages of care in the hospital, you're going to be more of a kind of multifactorial reason for this. Certainly, if you have just a community-acquired cause for acute kidney injury, it's usually kind of a single issue that's going on there, either a single medication or a single disease process. You guys think of like any disease states that might cause acute kidney injury? Rheumatic fever could be a good one. Anything else? Lupus, yeah, absolutely, yeah. So again, usually a single cause that's leading to the acute kidney injury, right? Versus when you're in the ICU, it could be you're hypovolemic due to sepsis, and then you also have an aminoglycoside on board that you're using to treat Pseudomonas, and then X, Y, and Z. Normally, you're going to see the mortality also be much higher as you get into more kind of the complicated cases, especially in the ICU. But other risk factors that you're looking at. So if you're looking at the community, basically if you're an elderly patient, typically have less hemodynamic reserves, they're more likely to have acute kidney injury, plus they've already probably had some degradation in their kidney function anyway. Sepsis, dehydration, infection, all those things can be playing a role here. And then as you get into the hospital, then you worry about things like more volume depletion, you worry about surgery and things like that. So lots of different reasons why a patient may have a kidney insult, usually in the hospital, those multifactorial. So basically the way we're going to manage it, though, is based on the type of kidney injury that we are seeing. So have you guys covered this at all? Like pre-renal versus intrinsic versus post-renal kidney injury? We'll go over it briefly, but we'll talk about some of the different ways that we can see how drugs can be affecting this. But pre-renal kidney injury, how would you kind of describe that to a patient? Yeah, good. So decreased blood flow to the kidney. So what could be a cause for that? Hypovolemia is probably the biggest one that we were going to run into, right? So you have a patient who has really bad gastroenteritis and they maybe are not able to take in fluids, they have an acute kidney injury due to volume depletion, right? So that's one of the big things we're going to see there. Basically, the kidney parenchyma is not damaged yet, it's just being hyperperfused, right? Then you can get to more an intrinsic kidney injury where you're actually having the structural damage to the kidney that's occurring. Either it could be an ischemic insult, which you can have pre-renal turn into ischemic kidney injury, could have some other toxic insult that could be causing this, and there's more of a post-renal, which is probably less frequent that you're going to see. There's more related to obstruction of urine outflow. So any reasons for that you could think of? Could be tuner. Yeah, kidney stones are another big one. Yeah, so all those things could be causing a post-renal obstruction, which is preventing kind of good flow through the kidneys. So again, you've seen pictures like this before. Looking at where the kidney injury is actually going to be occurring, you can kind of see here for the pre-renals, again, it's going to be happening before you actually get to the kidney itself. So if you were looking at something like NSAID-induced kidney injury, how would you describe that one, do you think? Probably pre-renal, right? Because it's affecting what type of arteriole? Afferent. Right, it's affecting the afferent arteriole. It's not allowing it to, it's causing it to constrict too much, right? Because you don't have those prostaglandins, which are normally vasodilatory. That'd be a kind of a pre-renal injury, okay? Not to say that drugs can't cause one or the other, right? So sometimes you'll see some drugs that will cause maybe a pre-renal and then eventually an intrinsic, or could cause an intrinsic as well as a pre-renal. But usually when you think NSAIDs, you're thinking something like that. Also, like ACE inhibitors would also be considered kind of a pre-renal kind of issue, because again, you're obstructing or preventing really good kind of that backflow pressure at the glomerulus, so you're not really filtering as well. And then obviously your intrinsic kidney injury is going to be happening more kind of in these areas, whereas the post-renal or obstructive is going to be happening more in the collecting duct and kind of further along in the urinary tract. Okay. So again, just kind of a nice table, just kind of showing you kind of the things you should be looking at when you're considering a patient with acute kidney injury, how you're going to kind of be working that up, looking at different laboratory tests, what their history is, what their clinical presentation, all those kind of things. We'll talk about, a lot of different causes for this, but we're going to look more specifically at a lot of the drug-induced causes and how we can kind of get around that and potentially treat those. Again, just a way to break these up, things like BPH, we talk about tumors and malignancy being a big cause for a lot of post-renal kidney injuries. So obviously, drug therapy can change pretty drastically depending on what the etiology of the obstruction is going to be. So with acute community-acquired acute kidney injury, again, very frequently secondary to renal hypoperfusion, so volume depletion is going to be a big one. So they're having a lot of vomiting, diarrhea, dehydration, all those can be big reasons for having that kind of pre-renal kidney injury. Sepsis is another big one. And we mentioned ACE inhibitors, ARBs, diuretics could also cause this as well. Diuretics just because you're causing a volume depletion throughout the whole body, so that can lead to that pre-renal kidney injury, right? Looking at hospital-acquired and ICU stays, we're more frequently going to see it being more of an intrinsic issue, right? So acute tubular necrosis is probably going to be one of the most frequent causes for acute kidney injury for these patients. So the risk is going to go up as you get patients with decreasing GFR, especially if they have increasing age. Age is going to be a big factor here as well, and kind of what degree of renal impairment they already have kind of coming in to see you, and what type of kind of chronic kidney diseases especially can lead them to be more at risk for having acute kidney injuries. But other things, critical illness, septic shock can all be a big one. Any kind of chronic organ impairment, liver impairment, lung impairment can all be leading to this. And then obviously nephrotoxic drugs is going to be a big one. A lot of cases you may not be able to get around it, and sometimes you have to use nephrotoxic drugs, but there are certain things you can do to try to mitigate the damage you're actually doing to the kidneys itself. So do you guys remember what we did for aminoglycosides in order to kind of help limit the toxicities but still have really good efficacy with the drug? Not necessarily every, so sometimes you have to give it every other day if they have bad organ impairment, but traditionally we would give the drug 3 times a day, so every 8 hours. And then what we found was, because it's a concentration dependent killer, if you just give it 1 time a day, much higher levels kill the bacteria, you actually end up kind of decreasing the total body burden of those aminoglycosides, and saw less acute kidney injury from that. So we'll talk about strategies like that can be useful for trying to mitigate the damage you're doing. So again, pre-renal AKI is going to be this hyperperfusion of the renal parenchyma. Again, often the causes can be related back to illness in a lot of cases. Burns can be another big case. If you ever get a chance to work like in a trauma center, have a burn unit or something like that, like those patients require tons and tons and tons of fluid because they're depleted themselves pretty significantly. Diuretic therapy can be another big one for this as well. So also the systemic vasodilation, so sepsis is probably the most common cause for this one. The vascular endothelium gets very leaky. There are third spacing fluids outside of the vascular space, and so that can be another big reason for hyperperfusion. And then sometimes you can even have things like renal artery occlusion. This is where you can have things like ACE inhibitors and NSAIDs kind of be affecting the blood flow to the kidney itself, rather than specifically having a total volume depletion. So what kind of compensatory responses do the kidneys have when you're having an acute kidney injury, especially pre-renal? We're going to be activating what system, do you think? ROS. Yeah, that ROS system, that renin-angiotensin-aldosterone system, because we want to try to get the volume back up. So we're going to increase things like antidiuretic hormone, we're going to be increasing aldosterone, try to do things to try to hold on to more water and salt, and we like to constrict down the blood vessels that we can. So sympathetic nervous system is going to get upregulated, the ROS system is going to get upregulated, and so that's why your patients are going to become more thirsty. They're going to have that, if they want to take in more water, it's related back to the antidiuretic hormone. And then you're going to see more prostaglandins used to help dilate that afferent arteriole, and then angiotensin 2 is going to be used to kind of constrict down on the efferent arteriole, right? So this is where you can see these medications can be affecting that. A lot of times, though, you can see those compensatory mechanisms kind of being overwhelmed, and the patient's still going to be hyperperfusing regardless of how well they're trying to compensate for that. So again, functional acute kidney injury, ACE inhibitors and ARBs are probably going to be the biggest cause for this. Patients with heart failure already are going to have problems with managing their fluids anyway, so this can kind of compound that. And obviously NSAIDs are going to be another big one we've already mentioned here. Vasopressors are kind of interesting. So can you guys think of any vasopressors you might use for patients? Really talked about them extensively, but you're thinking about things like norepinephrine. You guys ever heard of that drug? Right? Things like epinephrine, dopamine, like all use as vasopressors. They work as vasoconstrictors in order to help elevate blood pressure, right? One of the things, though, is that when your body is trying to keep heart to the vital organs, where's it trying to send it to most likely? The heart and the brain, right? So your kidneys can kind of take kind of a backseat to that. So in a lot of cases, you may have patients who are on vasopressors like norepinephrine or dopamine, and the body is not necessarily trying to keep that blood flow to the kidneys as much as it is tried to the heart and the head. So you can end up seeing hyperperfusion from that standpoint, right? So it's not uncommon you would end up having patients have acute kidney injury kind of being exacerbated by this vasopressor use. It's kind of odd because they're hypoperfusing because they're hypotensive, so we're getting vasopressors, but then that's even worse and kind of worsening the issue. So a lot of times fluid management is going to be really, really important for these patients as well. And again, once you fix the initial problem with the pre-renal AKI, if you can reverse that early on enough, you're not really going to have to worry about any kind of long-standing kidney injury, right? But if it's prolonged and you have this kind of ischemic insult on the kidneys, that's where you can see acute kidney injury or intrinsic kidney injury actually start to take place, right? So if I can reverse this early, don't expect to have any long-term effects, but if I leave it long-standing, if they're in the ice or if they're in the nursing home, they're dehydrated and they'll get looked at for a week, then that's where you can run into problems where they're going to develop this intrinsic kidney injury as well. So looking at intrinsic kidney injury, this is going to be damage either to the vasculature in the kidneys, the glomeruli, the tubules, or the interstitium. So usually things that you can see causes for this include things like embolus dislodgement, especially during surgery. That can be one possible cause. Smaller vessels can also be occluded as well. We can see some issues, especially with like kind of rapidly elevated blood pressure can be affecting this and can affect the microvasculature. So any of these things kind of blocking blood flow can all lead to kind of impaired, lead to that kind of ischemic insult. That's kind of one way we can have the vasculature being damaged there with intrinsic AKI. But looking at the glomerular damage, this is not going to be super common, but we'll talk about glomerulonephritis a little bit later. But then looking at tubular damage, this is probably where the most causes of intrinsic kidney injury is going to be happening here. So a lot of it can be related back to this kind of pre-renal state, where if you kind of left them pre-renal for long enough, that's where you get that ischemic insult. So again, 50% of it is going to be related back to that. The rest of it can lead to things like myoglobin precipitating out in the kidneys, hemoglobin, uric acid. Can you guys think of any drug-induced causes for that to occur? Okay, yeah, so uricosuric. So like if you had some, like what type of drug? Yeah, probenecid. So probenecid would end up trying to increase the excretion of uric acid, but if you keep it in the renal tubules for longer, they can precipitate out and they can lead to issues from that standpoint. Yeah, so that's one way it could happen. Anything else? Why would a drug cause a lot of myoglobin to be entering the kidneys? When do you have a lot of myoglobin hitting the kidneys?
Muscle crush.
Right, so crush injuries to the muscle, which we call rhabdomyolysis, right? So is there any drug-induced causes of rhabdomyolysis? Statins, yep, that could be a big one. What else? So think about things like serotonin syndrome or that neuroleptic malignant syndrome where your patients are really kind of tight. Malignant hyperthermia can be another big one. So those can all be drug-induced causes for having myoglobin, muscle breakdown, myoglobin leading to obstruction within the kidneys. Think about tumor lysis syndrome, right, for your leukemic patients. When you lyse all of those cells, all that uric acid is going to end up hitting the kidneys. That can be another big cause for that. So lots of different reasons for that to occur. This is where also you'll see things like aminoglycosides can cause interstitial damage, and also things like contrast agents. We'll talk about that a little bit later and talk about contrast-induced nephropathy. That is a very big concern. It's a really big thing you want to try to avoid as much as you can in your patients. Eventually, yeah. So it depends on kind of the severity of it, but obviously the longer they're in that state, the more likely they are to have a breakdown that can occur. So, right, so I see, most frequently I would end up seeing issues with this where, it's during the summertime, you have patients who are really committed to, getting in shape, and so they go to do these boot camps, and then they go and they get super dehydrated. They have some mild degree of rhabdomyolysis, so their kidneys are hyperperfused, and then now they have this increased myoglobin hitting the kidneys, which is causing precipitation and interstitial damage, and so those are the patients that can kind of run into some problems with that most frequently is what I end up seeing, at least here in Florida. It's hot, and they're just not really adapted to exercising very well, so I've seen several cases like that. Also, they end up having kind of the psychogenic polydipsia, so they end up getting a hyponatremia along with it. So those patients can be pretty complex when you run into them. But so again, when you're looking at acute tubular necrosis, you have this kind of initiation phase that occurs where you can have an ischemic injury causing necrosis and apoptosis. You have actually the cell death happening there, and then they have issues where they can't regulate the fluid and the electrolytes across that tubular lumen. So normally they're either secreting or reabsorbing things like fluids and electrolytes, and that kind of goes out by the wayside. You also are going to have this glomerular filtrate leaking into the interstitium, and that ends up getting reabsorbed. And so we call this, we kind of call it dumb kidneys, where some of these patients may still be producing urine, but they're not really able to regulate waste excretion or reabsorption of things like electrolytes. So they have all kinds of abnormalities that are coming from that standpoint. Usually this is happening kind of over hours to days, and so you're going to notice this either by looking at impaired urine concentration. So you're going to be doing urinalysis to kind of look to see how they're actually concentrating things. Then you're going to see things like decreased urine output, and then eventually a decreased GFR, right? Again, because usually serum creatinine is going to lag behind, and serum creatinine is how we measure our GFR, is how we calculate it. And then once you have the actual the insults kind of taken away and you have actual recovery, this can take weeks to months depending on the degree of damage being done, right? So pre-renal, if you can reverse it quickly, no really long-standing issues. But here with the more intrinsic kidney injury, if you don't, the more long-standing it is, the longer it's going to take to have full recovery. So you're looking at interstitial damage. You have acute interstitial nephritis. Usually this can be caused by certain medications. We'll talk about those a little bit later. Infections, autoimmune diseases is where things like lupus can pop up here. And usually you're going to see lesions that are composed of a lot of kind of pro-inflammatory cells. That's where you see the monocytes and macrophages and whatnot. These are generally can be reversible as well if you can get it treated or reverse the cause, whatever happens to be. So in cases like autoimmune diseases, giving things like steroids and whatnot can help to reverse that a little bit more quickly. Okay, and then postrenal AKI, usually this is less than 5% of all cases, so it's a relatively uncommon thing, but it can occur anywhere within the collection system. Usually you can see obstruction happening. BPH is a very common cause for this, or prostatic cancer. What would be one way you'd want to treat that? How do you think you can decrease the prostate size? We'll talk about that a little bit later in urology, but any thoughts? Resect it, so you can just chop it out, right? We're thinking like pharmacologists here, so maybe not that far. So yeah, so there's some things you can actually do to relax the prostate to actually allow for flow to happen a little bit better. So you have flow max, which are tamsulosin, which actually helps to release some of that constriction there. But you can also do things that actually deal with the enlargement. So we talked about what is a hormone that increases the size of the prostate. Testosterone, and DHT is another big one. So we'll look at drugs that actually block that conversion and limit the amount of DHT you have, so that way you can actually help shrink down the prostate. So we'll talk about that in the urology section a little bit later. Anywho, other things you can see, if you have oxalate crystal deposition due to drugs. So there are cases where you can have things like thiazide diuretics can lead to oxalate crystal deposition because other types of diuretics can do this as well. Oftentimes we run into this from a tox standpoint when we have ingestions of ethylene glycol or radiator fluid. You can actually have that drug end up generating a lot of calcium oxalate crystals that cause some interstitial damage and also some post-renal acute kidney injury as well. That can be kind of problematic. Don't drink radiator fluid, it's a bad idea. But and then drugs with poor urine solubility, so things like this can precipitate out. So like methotrexate is going to be a big one here, especially when you see a lot of like cancer patients. They get on very high dose hydration therapies to make sure they don't have methotrexate precipitating out in the kidneys. That can be a big one. And then also that tumor lysis syndrome we mentioned, which is mostly just uric acid. So how should these patients be presenting? Usually changes either in the amount of urine that they're producing or the actual color. Obviously, if they have something like rhabdo, it should be yeah, cola color. Yeah, so they're like, oh, it looks like tea. Like I don't know if you guys are on Reddit or not, but there's always like these really bad posts where someone's like, my pee looks like tea. What should I do? And they're just like, go to the doctor. Like, I don't have insurance. I'll just wait it out. Nope, go to the doctor. You're gonna die if you don't do this. Like those are bad. Well, that's usually the only thing that gets people to actually go in. But yeah, so sudden weight gain can be another thing. So if they're not really able to regulate fluids well and they're starting to put on weight, abdominal flank pain, So once you have this starting to occur, then you can kind of start to determine, is this an acute issue? Is it more of a first presentation of chronic long-standing kidney injury, or is this an acute on chronic issue? Very often you'll have patients who have history of chronic kidney disease that have an acute insult that will end up leading them to have this acute on chronic kind of decrease in kidney function, right? So acute on chronic just really means that they're already kind of decreased function already, but then they have kind of another drop in that due to infection or whatever it happens to be. Usually it's easier to determine for an inpatient than it is for an outpatient. Why do you think that is?
They're not monitoring their output or their creatinine.
So monitoring is easier on the inpatient side, so usually you can kind of catch it as it's developing. What else? Okay. Yeah, exactly. Yeah, so you have a lot more control of their environment when they're in-house, right? So you can determine, okay, what drugs did they receive, what what are their other kind of things that have been going on with the patient, versus if they're outpatient, like they could leave out something really important, like, oh yeah, I just went to a boot camp and that's why I have rhabdo now. So things like that where they might not be able to provide as good a history. So usually inpatient is a little bit easier, even though it could be multifactorial, it could be several things going on. So also, what are you going to be looking for? So chronic conditions obviously can be influencing this. You want to figure that out. The medication history can be super important. Make sure you're asking about over-the-counter products, right? A lot of people don't think about Advil and Tylenol as being prescription drugs when you ask about that. So make sure you ask about over-the-counters, ask about herbals, can all be affecting this. Any lab studies you might have previously. Very frequently, I always, if you have a patient who's coming in and their serum creatinine, like what's a normal serum creatinine, did you say? Yeah, around 1 is usually pretty good. So if a patient comes in and they're 1.5 or they're 2, the first question you should ask is, well, is this their baseline or is this new for them, right? If it's an otherwise healthy patient that you've never seen before and they're good, that could be brand new for them. That's pretty easy to figure out. But if it's an older patient, they come in, they're 70 years old, their serum creatinine is 2, that could be just their baseline, right? And so it's good if you have previous labs you can kind of refer back to and figure that out. Any procedures and surgeries, and then also things like recreational drugs. We've seen lots of cases where patients are abusing some of these new amphetamine-like type drugs that are causing potential rhabdo. It can lead to acute kidney injury, so there's been several cases of that. So be sure to ask about recreational drugs as well. Again, you guys are going to spring break, so I'm sure none of you will ever partake of those, but just keep that in mind. Again, look for trends in laboratory data. You want to make sure you're not just looking at a single point. You need to see if there's any kind of trend that's going on. So serum creatinine, there's some several limitations to using serum creatinine as your sole means of assessing a person's urine, their kidney function. It's going to vary with age, gender, muscle mass, diet, and hydration. So for instance, if you have a patient who has, say they're a 18-year-old, they are a football player, and they're on a high protein diet, you would expect their serum creatinine to be probably higher than what it actually, so they could have a serum creatinine of 1.5 or 2, and you'd be like, man, that seems really high, but that could be just their normal, right, based on their diet and their, them working out a lot and things like that can produce that. If you have a very elderly, old patient who's very, very frail, obviously they're going to have a smaller amount of serum creatinine they're producing just because they have less muscle mass. So think about things like that. What did you think about an amputee? Yeah, they should have a lower serum creatinine because they've lost that muscle mass, right? So they can be falsely lower than what they're. So when you do the creatinine calculation or do their GFR based on the Cockcroft-Gault equation, their serum creatinine will be falsely low, and that's going to elevate their function higher than what it should be. So the other thing to consider is that it takes, just like everything else, serum creatinine has a half-life, and so it takes time for it to get to a new steady state. So just because you have an acute kidney injury does not mean that your serum creatinine is going to immediately jump up when you measure that in the blood. It's going to take some time, a slow accumulation, and so you have the potential to have kind of a later diagnosis on what you could if you're also looking at things like looking at the urine output. Like urine output can change pretty much immediately versus serum creatinine takes a few days. So always kind of take everything into account when you're doing that. Calculations can also over or underestimate the GFR depending on your patient population. So if I use the Cockcroft-Gault equation, which is made for adults and pediatrics, I don't really get a good answer out of that, right? So you need to make sure that you're using the right equation for the right patient population. Okay, just be aware of that. And the graph kind of shows you kind of what this can look like, where you're looking at things like the GFR. Here it's kind of just going along normal. You see the serum creatinine here. Here's where you have the insult, and then you can have an immediate decrease in the actual GFR, but the serum creatinine is going to take time before it really kind of picks up. Okay, so again, you may not notice it until it gets to this point when you have that kind of 50% increase in the serum creatinine, but they've been at a lower function that whole time. Unless they're accumulating drugs, they could be not clearing a lot of waste products, and so it can be leading to some other issues there. There are probably some biomarkers we can measure to detect this earlier, but a lot of these are not widely available in the hospital setting, so no, you can't really rely on those yet. Okay. You can also look at things like the urinalysis. I'm not going to get super in-depth on this because I'm by no means a urinalysis expert. During fellowship, though, they did have us learn how to do urine drug screens by taste alone. So I'm good on that standpoint, but very gross. THC has a floral kind of taste to it now. So anyway, so you can look at the urinalysis to kind of give you an idea of what type of kidney injury is occurring here. So you can kind of differentiate between prerenal, intrinsic, and postrenal. The thing I would do very frequently from the pharmacist standpoint, especially patients coming into the emergency department, to try to determine is this more prerenal or intrinsic or postrenal, is looking at that the BUN to serum creatinine ratio. So I'd actually look at that, and so if you look here at prerenal, you notice that the BUN can climb much higher or more quickly than the serum creatinine does. So if you see something like a 40-to-1 ratio or higher, that usually is indicative of a prerenal kidney injury, right? So that way I can just go ahead and how would I treat a prerenal kidney injury most frequently? Lots of fluids, right? So you're just going to give them some normazoline, you're going to tank them up, and then all of a sudden you can remeasure their serum creatinine, you can redo the calculation, all of a sudden the BUN comes down and they actually have a normal kidney function, right? So it's one of those things where oftentimes you don't want to just use a single set of labs. Very frequently, especially when you're thinking prerenal, you get those labs, you can tank them up with some fluids, and then you'll recheck it a couple hours later and they look right as rain, right? So that's what we run into a lot of times, especially in pediatrics with our CF kids. They come in very, very dehydrated, so it looks like they have bad kidney function when we know they don't. That's not really the case. We tank them up and then they look fine. So always keep in mind the patient situation there. But you can look at other things like the cast. You can look at the looking at things like the urine sodium concentration, whether or not they're concentrating appropriately. And so we'll look at that a little bit more when we talk about hypo and hypernatremia. But just be aware there's a lot of differences there. So anyway, so how can we prevent acute kidney injury? If it can be predicted, hopefully it can be avoided. And so this is really important on the hospital side, where especially if they're going to go for surgery, if they're going to go get chemo, if they're going to go for imaging, or they need IV contrast, like we can do things to help hopefully prevent the kidney injury from occurring in the first place. So one thing we can do is aggressive hydration prior to major surgeries or contrast. Very frequently we will be giving some of our chemo kits, so say you have like a normal kind of like say 50 kilo adult, 50 kilo like adolescent who's going to be getting some high dose methotrexate. We'll be giving them something like 300 to 400 mLs an hour of fluids in order to really make sure their kidneys are well perfused, make sure they're really tanked up intravascularly for the time preceding or right before they get the methotrexate for a few hours afterwards as well, right? So all those things we can do to help really avoid that kidney injury. Also, just make sure they have adequate fluid intake as well. It can be really important. And then avoid our nephrotoxic meds. We'll talk much more about those in detail in just a little bit. Obviously, our thing we would like to do here is if we can screen and identify patients at risk, we can look at their med profile, make sure they are avoiding nephrotoxins. What's a big thing you worry about with a certain diabetic med and patients getting contrast? Yeah, metformin's a big one, right? Because you worry about causing acute kidney injury and having buildup of metformin levels leading to lactic acidosis. So those are things you're going to be screening for. And then you can monitor until either the risk has subsided or the patient has shown that they're doing okay. And then hopefully we'll look at some kind of preventative strategies and how some of those are more or less effective for the most part. But in general, the best thing you can do to prevent kidney injury is just to really tank up your patients with fluids and make sure they don't have any nephrotoxins on board. So again, hydration is very consistent in showing benefit here for prevention of acute kidney injury. So we talk about crystalloids and there's colloids. What's the difference between the two? What's a crystalloid?
Salt, ionic.
Salt.
It's a solution.
Yep. It's yeah. So both of these are solutions, but this one's going to be salt-based, right? So what are some examples of crystalloids? Normal saline.
Lactated vinegar.
Lactated vinegar. Can you think of any other ones? Those are the most common ones you're going to run into, right? Certainly you have different concentrations of different things. So normal saline, we don't always use normal saline. Sometimes we use half normal saline or quarter normal saline mixed with dextrose, right? So lots of different crystalloids there, but again, they're all going to be basically salt-based, right? This is going to be cheaper. It's going to have less side effects than using our colloids, which colloids are typically going to be some sort of like protein-based kind of products. This is where you have albumin that can be given. This is where you have things like hetastarch. They're sometimes given in surgery and things like that. Basically, they do the same thing. They will increase intravascular volume. They just have a different constituent of what is actually in the solution itself. So say, for instance, you have a patient who has a very low albumin level, and albumin is really important for helping to maintain intravascular volume. Well, I can give them lots of crystalloids, but if at all third spaces, it doesn't do me any good. So maybe I can replace their albumin, right? So looking at kind of the what's going on with the patient, you can kind of guide you to deciding what type of fluid you want to use for those. But in general, crystalloids are going to be the best thing to go with, especially for kind of acute patients coming into the ER, like they're getting crystalloids. Actually, in some of the colloids themselves, they can actually cause kidney injury as well, and there's some bleeding problems you can run into. So typically avoid colloids unless you have like a really specific reason that you need to use that. Okay, so why is normal saline normal?
Isotonic.
Isotonic, yeah, absolutely. So it's 0.9% NaCl, right? So if you ever see like half normal saline, that would be 0.45%, and quarter normal would be, it's like 0.22, yeah. So I know math gets really hard when you get down to odd numbers, but yeah. So basically, what this just means is 0.9 grams of sodium chloride per 100 mLs of fluid, right? That's what that percentage means. But essentially, it's 154 milliequivalents of sodium per liter. But you also have 154 milliequivalents of chloride at the same time. So if you're looking at normal serum sodium, usually 135 to 145. So okay, that's pretty close. So that looks good. And then looking at the serum osmolarity or osmolality, I'll probably use this interchangeably because I'm not good with osms and all that. So anyway, it doesn't matter for our purposes. But anyway, right around 300 is where your patient should be sitting. And if you take 154 times 2, 308. Yeah, so 308. So it's pretty close to serum osmolarity as well. So it's isotonic, that's great. Now, certainly you can give isotonic volumes of dextrose, something like D5, which, you know, D5 is somewhat close to isotonic with the blood, but when you're looking at where the fluid goes, you need to make sure that, especially when you're trying to replete the patient with volume, you want to keep it in the intravascular space. And so when you give just plain D5, we call that free water, where the water can basically just kind of go out into the extracellular space. None of it really stays in the intravascular space, right? So you need salt within the bloodstream in order to help bring water in there, right? Dextrose can just kind of freely diffuse across, and so it doesn't really stay within the intravascular space like you want it to. We'll talk more about that a little bit in detail later on. We're looking at kind of where fluid goes based on the type that we give, unless it's on the next slide, which I'll look kind of silly. Nope, it does not here yet. So we'll talk about it later. Anywho, so other things that we can try to do to prevent acute kidney injury. There's lots of things that people have tried, but don't really work all that well. So it's things like loop diuretics could be potentially used here. So some people were like, okay, well, if we increase the urine flow through the kidneys, we can help to flush debris and things like that. We'll give a loop diuretic and that'll work, right? So some examples of loop diuretics. Lasix, which is furosemide. Yep. Any other ones? Bumax, which is bumetanide. There's torsemide. There's also ethacrenic acid. Yeah, so there's several varieties that are out there. Again, they're all going to be working on that. Which lupus family? Descending or ascending? It's the ascending loop of Henle, absolutely. All right, so they're blocking sodium reabsorption, so more sodium out in the renal tubule, more water is going to follow that, and that's how you get the diuretic effect, right? All this stuff keeps coming back, guys. It'll happen. Also, they thought that, you know, maybe by inhibiting this process, you may have decreased oxygen demand. Maybe that'll help with some of the ischemic insult. Not really found to be super helpful. Other problems you run into is you also run the risk with patients with poor kidney functions. You can have ototoxicity that can occur, right? So that can be problematic. And so we'll see that occur, especially with some of the other nephrotoxic meds we'll talk about, namely the aminoglycosides. Aminoglycosides can also cause ototoxicity. So again, that's one of the things I'll often look at, where if a patient is on a loop diuretic, say like a continuous infusion of furosemide plus an aminoglycoside, that's one of the first things we ask about. Okay, well, you know, what about the hearing function? What about the ototoxicity there? Again, if your patient's ventilated and they're sedated, can they tell you if they can't hear very well? Probably not, right? So that's one of the things you need to kind of think about before it occurs and they wake up and they're like, huh? Like, you don't want that to happen. So anyway, other problems with loop diuretics is if you cause you know, that diuresis, you can decrease the intravascular volume, which again is not what we want to do. That can lead to pre-renal acute kidney injury. So really, loop diuretics are only going to be good if you have pre-existing fluid overload. So what type of patients might have that? CHF, like bad cirrhosis, things like that. So they can have fluid overload as well. So those would be the big ones you'd want to consider that for. If they have fluid overload, loop diuretics can be useful in this case. But other things we can try using, renal vasodilator. So if people try things like dopamine. Dopamine is usually used as a vasopressor. Usually it's used to increase blood pressure, but it's all dose dependent. So what you see is that at very low doses of dopamine, something between like 1 to 5 mics per kilo per minute, it actually causes activation of dopamine receptors in the kidney and actually causes vasodilation. So the thought there was increase kidney blood flow. You're going to help hopefully to prevent that injury. The higher doses than that is where you get to more of the adrenergic kind of effects, and that's where we're going to see increased heart rate and increased blood pressure as well. Unfortunately, that one doesn't really work as well. Phenoldiprime is another dopamine agonist, again, not super beneficial for a lot of these patients. So you are starting to see where, like, okay, you can try lots of different things, but really tanking them up with fluids and limiting nephrotoxic meds is the best way to hopefully prevent acute kidney injury. People will sometimes try antioxidants. So if you're having ischemic injury occurring in tissues, you're generating free radicals, right? Those reactive oxygen species, which can go and cause apoptosis, can denature proteins, all kinds of bad things. So by giving antioxidants, hopefully you can help prevent that from occurring. Some people try ascorbic acid or vitamin C with some, this is one of those things where it's like, well, it's pretty low cost. What are the side effects of giving too much vitamin C? Right, there's none. So you can give it, and it's not really going to be a problem for them. But again, we don't really have consistent results with this, so maybe not super useful. One thing I will see some people try is N-acetylcysteine, otherwise known as Mucomyst. This one is sometimes given as a mucolytic to help kind of break up mucus secretions in the lungs. It's also used as an antidote for Tylenol toxicity. So that's where I use it most frequently. Does anyone know, I guess I already put it on there, but it smells like rotten eggs basically because it has high sulfur content. That was one of my first jobs as a intern in a hospital pharmacy. Was I got to be the one to take big vials of N-acetylcysteine and put them into little vials for the RTs to nebulize for patients. So I got to sit there and smell that stuff like every single week, and it was terrible. But yeah, so get a sniff of that if you ever get a chance to. But anywho, acting as a free radical scavenger, hopefully can help to prevent a lot of that damage that's being done there. And so I've actually seen this used several times in some really high-risk patients. So for instance, like over at Nemours, we had a patient who was in the ICU who had had chronic kidney failure, was on intermittent dialysis for that, and needed to go get imaging done. And so they didn't want to hurt the kidneys any further with IV contrast, so they actually ended up doing was giving him a few days worth of N-acetylcysteine beforehand, and then continued it for about a day after the actual contrast was given. Okay, I don't know if it actually did any good, but it's one of those things where it's low cost, low side effects, so it's like, okay, we'll try it and see if it works. Sometimes that's how medicine goes. You don't necessarily know the right answer, but you'll try stuff. So again, treatment of acute kidney injury that's actually already occurred is basically revolving around eliminating the insult that's happened there, right? So we want to do good supportive care, and then we might need RRT or renal replacement therapy. Have you guys heard much about dialysis previously? Or some, well, I guess what is dialysis?
Artificial filters.
Artificial filter. Okay. What does that mean?
They're running the blood through a machine to do what the kidneys should be doing.
Exactly, right. So we're taking the blood out of the patient, we're running it through what we call a dialyzer, which is, they're kind of cool looking, they're kind of really kind of intricate filters, but basically it's taking, and you're kind of running dialysate through it as well, kind of a counter current, right? So you have the solution that's running through it, and basically the debris and the waste products in the blood, they're in high concentrations in the blood, will get filtered out into the dialysate that gets just gets eliminated, basically, and then you pump the blood back into the patient, right? So dialysis can be done as a way to kind of supplement what the patient's kidneys are not doing. There's lots of different ways to do this. There's intermittent dialysis, which may be given for several hours a few times a week. So you may have, we'll talk more about that in chronic kidney disease, but sometimes we'll have patients who may need to go on things like continuous renal replacement therapy, where they're actually on a dialyzer 24/7. It's usually like in the ICU type patients. We'll talk more about that in detail just a little bit later. But usually if you have an acute kidney injury due to something like contrast-induced nephropathy, things like that, hopefully you're going to have kind of recovery within about 10 to 14 days. It may take a little bit longer depending on your patient, especially if they have other comorbid conditions, things like that. But here we'd like to minimize the insult as best we can, hopefully reduce any kind of extrarenal complications that are occurring as well, and then hopefully expedite the recovery of the kidneys, right, by giving good supportive care. So with dehydration, how are we going to fix that? Obviously, we're just going to give them fluids, right? So again, a good fluid bolus is going to be 20 mLs per kilogram as a good dose, right? It's always a good number to keep in your head, especially if you're dealing with pediatric patients or any other type of patient. Usually that works out to be about a liter to 2 liters for an adult patient, right? But if you have a guy who's like 400 pounds and you give him a liter of fluids, probably going to laugh at you. So it's not really going to do anything for him. So you always consider, you can always give him more fluids if you need to. How do we monitor to see if the patient is intravascularly repleted? Like, what are some of the things we can look for? Blood pressure is good. What kind of blood pressure are you looking for? Put it on the slide. So what's a MAP? Besides, it tells me where to go. Okay, good. How do you measure that?
Yeah.
The computer spits it out. Do you guys know how to calculate mean arterial pressure?
Is it the average between the systolic and the diastolic?
It is, but there's a specific ratio to it. Because what does your heart spend more time in, systole or diastole? In diastole, right? So basically, you take your blood pressure, you do 1/3 of your systolic blood pressure and 2/3 of your diastolic blood pressure, and that's your map. So go and press some preceptors with that if you can whip that one out. Yeah, usually the monitor just spits it out for you and just look at it and be like, okay, that's a map. Great. Usually 65 millimeters of mercury is what you're kind of shooting for in a lot of cases. And then also you're looking at urine output. You'd like urine output to at least be 0.5 mLs per kilo per hour. Anything over that is going to just be gravy at that point. Okay. Obviously, when you're giving fluids, you want to make sure you're not giving too much. That will be evidenced by things like pulmonary, peripheral edema, electrolyte imbalances. Hopefully, you want to see they have normal glycemia. This is why we include dextrose in a lot of the maintenance fluids that we give in order to make sure the patient is still getting some sugar. We're not diluting all that out. So that's why you see a lot of like D5, half normal saline being given, things like that. Okay, for patients who are anuric or oliguric, or you're worried about fluid overload, you may want to give smaller volume. So sometimes we'll do half boluses, we'll do like 10 mLs per kilo. You may do 250 to 500 mLs at a time, because again, you can always give more, but you can't take it back, unfortunately, unless you were to dialyze them or something. So you don't want to have to do that. So patients with CHF, pulmonary insufficiency, those are the ones you want to be careful with, and make sure you're not giving them too much. Some of the problems you can also run into is if you give too much sodium chloride, you can actually end up giving, because I guess what's a normal kind of serum chloride? 110, 115. And we said in normal saline, what's the chloride content there? Yeah, 154 milliequivalents per liter. So if you give too much normal saline, you can actually run into this hyperchloremic acidosis that can occur. So that can be kind of an unintended side effect of giving too much normal saline. So in some cases, a lot of patients can compensate for that, and it's not a big deal. But if they have already pre-existing acid-base disturbances, that can be worsened by it, right? So you have to be careful with that. Some patients will end up going on a solution where you may be using half normal saline, and then you're giving the other 0.45% of saline as sodium bicarbonate. And that way they can kind of balance that out and kind of maintain kind of a neutral pH there, right? What's a normal pH for the blood to be?
7.4.
Yeah, 735 to 745 is usually a pretty good range to look at there. So hopefully you're keeping in that range and not causing them to become more acidotic. Because again, if you're septic and you're hyperperfusing, what is your pH more likely to do? It's going to go down, right? You're going to get more acidotic because you're having more, your tissues are moving from, aerobic to anaerobic metabolism because they're not oxygenating well. They're generating acids, lactic acid, so they're getting more acidotic. So you don't want to worsen that. So, and then obviously, if your patient is hypovolemic because they've lost a ton of blood, obviously you want to give blood. So in a lot of cases, they may be, especially in like trauma situations, you're going to be replacing with that along with, crystalloids and things. Okay, and then renal replacement therapy is going to be, this is where we can either do intermittent dialysis or we can do continuous renal replacement therapy. So again, this is for the acute kidney injury. Usually, for your chronic kidney disease patients who may be on dialysis for 4 hours, Monday, Wednesday, Friday. A lot of times patients end up coming into the ED because they missed their Friday dialysis session because they want to go somewhere for the weekend, and then they come in and they're just sick as snot. That's usually a common cause for patients coming in. Other things you can use dialysis for, I like to put it in vowels. It's easier to remember. So AEIOU is a way to remember things that dialysis can be useful for fixing. So one, acid-base abnormalities. So if you're acidotic, giving them a round of dialysis can help to fix their acid-base disturbance and get them back into a more neutral state. If you have electrolyte imbalances, so if you were hyperkalemic, too much potassium, you can pull that off of dialysis and help fix that. We will also do dialysis for intoxications. There's certain ones that are water soluble that can be dialyzed off. So things like aspirin can be dialyzed off. Things like ethylene glycol, we mentioned, like radiator fluid. Things like that can be pulled off in some cases. And then fluid overload, you can maintain the patient's fluid status by pulling off extra fluid during dialysis. And then uremia can be fixed as well with this. So those are usually the common causes for patients to go on dialysis, especially if they had not been on it previously. So again, a lot of it's related back to acute kidney injury, fixing electrolytes, fixing the fluid status, and hopefully fixing their pH. Any questions from the first half of the talk? All right, so we can continue on with our treatment of acute kidney injury. So you have to consider lots of things when you're looking at a patient's medication profile when they're having acute kidney injury. So look at things like how do you think volume distribution changes for say hydrophilic meds for a patient with acute kidney injury? So they're fluid overloaded. Say they're not, they're anuric and they're fluid overloaded. What do you think that does to the volume distribution? Increases it, right? Just like we talked about with infants and them being big bags of water, you saw higher volumes of distribution for hydrophilic meds, right? Conversely, more lipophilic meds are kind of lower volume distribution. That could be affecting the drug getting to the site of action. Again, look at the volume status of the patient to kind of assess for that. But also one of the biggest things we run into is antibiotic dosing in our septic patients, right? So we have to balance out the fact that we need to treat their infection, but also there may not be clearing these drugs very well. So you guys think of any antibiotics that we have to worry a lot about renal function? Aminoglycosides, yep, that's in one we already talked about. What else? Well, specifically like antibiotics. Yeah. So think about your penicillins. Think about your cephalosporins. Think about your carbapenems. Think about your fluoroquinolones. Think about vancomycin. Think about, what else? Another one. Like, there's a lot of them that have to be renally dose adjusted, so you really need to make sure you're monitoring for that and assessing that. So again, look at your patient, look to see kind of where their labs have been trending. You may need to be more proactive in some cases. So for instance, when we have our CF patients who come in for a pulmonary exacerbation, they're very dehydrated. They come in and their serum creatinine is, normally say it's like 1, and now it's bumped up to 2. Okay. Initially, you'd say, like, well, we need to renally dose adjust all their antibiotics to make sure that they are not accumulating too much drug and running into problems, right? That would be ill-advised because as soon as we replace their volume status, give them lots of fluids, and you repeat that serum creatinine, all of a sudden it's come back down to what their baseline is. So then you'd be like, okay, well, let me readjust them all again. So again, if you know your patient is fluid depleted and you know their raised serum creatinine is probably not true, then you can go ahead and dose normally. But then those other patients have a true kidney injury, you make sure you're dosing appropriately. Run into lots of problems if you're having drug buildup, especially with aminoglycosides and vancomycin, which are frequently given together. In a lot of these septic patients, you're having ototoxicity, further nephrotoxicity, all kinds of bad things can happen. So please keep that in mind. Make sure you're assessing their med list. Make sure you're dose adjusted where necessary. Even things like Zantac or ranitidine, you may not think about that one being renally eliminated, but that one has to be adjusted too. And that's a very frequent one I see not being touched on a lot of these critically ill patients' profiles. So just keep that in mind. Okay. And again, no agent that we have effectively treats acute kidney injury. We can't reverse the process. We can only kind of eliminate the insults and hopefully, give the kidneys time to recover themselves. But we can help to hopefully manage a lot of the complications that we're going to run into. So some of the things you can do to manage their volume status, we mentioned some of these diuretics previously. This is probably a newer one. It's called mannitol. This one is an osmotic diuretic. This one is only going to be given parenterally, and so it can be used for kind of acute. Usually you see this being used for things like cerebral edema. This is able to help kind of pull fluid off of the brain. So you see this a lot in traumatic brain injury and things like that. But this can also be used as a diuretic itself. This one we don't really recommend very frequently because it can also cause acute kidney injury due to the high osmolarity of the product. We'll talk about that, especially when we get to the contrast. The higher the osmolarity of the product we're giving, the more likely it can cause acute kidney injury for that. The other big thing, though, you have to filter this drug. You guys know why you have to filter it?
Does it not dissolve very well?
Well, it depends on the temperature, because as it gets colder, it actually crystallizes out. Do not want to inject that without filter first. So frequently a lot of hospitals will have like kind of warming boxes that look like little easy bake ovens. So you keep all your mannitol in to keep it nice and warm, because typically hospitals are kept a little chilly, and so that's where you can see a lot of this crystallizing out. I had one. The place where I did my fellowship, they have, it's a level 1 trauma center, and so very frequently use mannitol for these suspected cases of, cerebral edema, and so they had to use mannitol for this patient who was coming in, and all of it was crystallized. So the pharmacist at the time was like, okay, well, what am I going to do about this? How am I going to warm this up quickly? I'll use a microwave. Ran to the cafeteria, went ahead and threw this in the microwave, and what do you think happens to this in the microwave? So he went back to go pull it out of the microwave, and all of a sudden it exploded. Like the front glass of it exploded out. He said he had a big chunk of glass out of his badge. I don't know if I believe that, but so if it's already crystallized, chances are just don't use it. Try to find one that's a little bit warmer. You can put it, with the warming blankets or stuff like that. Try to keep it from crystallizing up. But you have to filter it, because otherwise it can cause an embolus, and that'd be bad. Loop diuretics are most frequently used for this fluid overload. So again, Lasix probably the most often one being used. Again, keep in mind that sulfa allergy, there may be some cross-reactivity there. So use things like ethacrenic acid might be a better option for them. We have bumetanide, torsemide are also available. They're just a little bit more potent. Some patients you're going to find may have what we call diuretic resistance, where you're given, say, oral doses of furosemide, you're not really seeing the same urine output as you were previously. There's a lot of compensatory mechanisms that can come about, because again, when your kidneys are losing a lot of fluid, like their response is like, well, we need to hold on to more, right? So for instance, with the loop diuretics working that ascending loop of Henle, what do you think will happen at that distal convoluted tubule? It's going to try to pick up the slack and try to reabsorb more fluid from there, right? More salt, more water tries to get reabsorbed. So, so you run into this problem where you get this loop resistance that can happen here. So, some things you can try to do to override this is switching from, say, oral over to parenteral administration. Some patients will use continuous infusion of loop diuretics to try to get kind of a continuous amount of activity. Because again, Lasix usually lasts about how long? 6 hours, right? Because that's what I call Lasix, lasts 6 hours. I didn't tell you that, guys, already?
You did.
I did, okay. You just forgot, you repressed all those memories. Understandable. Yeah, and sometimes you can actually use different agents. And so one of the things you can actually do is give a small dose of a thiazide diuretic to block that kind of compensatory effect in the distal convoluted tubule, and you'll get diuresis happening again. So if you ever see something like, you guys remember the thiazide diuretic you can use in renal failure? Metolazone, right? So again, things like hydrochlorothiazide, things like chlorothiazide don't really work if your creatinine clearance is, say, less than 30 mLs a minute, but metolazone will still retain activity. Loop diuretics you can use, any creatinine clearance, it doesn't really matter, but the thiazides do not have that that kind of leeway. Only with metolazone can use it in lower creatinine clearances. Anywho, so just keep that in mind. You might see that loop diuretic resistance. There are ways to overcome that we can try. Okay, mentioned doing this. Metolazone or zoroqualin is the main one we're going to be seeing being used there. You can also use agents that work at the collecting duct as well, so things like amiloride, tramtrine, or spironolactone may be potentially useful as well. Usually, though, we just add on the metolazone, and that works very, very well. I had one nephrologist say that metolazone can make a rock pee, so figure, well, if he's got his seal of approval, it's probably pretty good. Okay, so what do we do with electrolytes? So lots of electrolyte shifts can happen when you have acute kidney injury. Looking at hypernatremia being a big problem, especially fluid overload, hypernatremia can occur. Some things we can do are to limit sodium intake. May make your loop diuretics a little bit less effective. That is one thing we can try doing there. A lot of the renal replacement therapies can help to fix a lot of your electrolytes. So if you're hyperkalemic, you can pull that off. It can help to fix things like your magnesium, phosphate, things like that. In a lot of cases, you may not be able to pull as much phosphorus or mag off. So if you have really high levels of those, in which case you may see that in cases like trauma, rhabdomyolysis, tumor lysis syndrome. Big things you want to do is avoid calcium. You guys know why you want to avoid calcium in those cases? So we'll talk about this in chronic kidney disease, but calcium and phosphate, they like to precipitate, right? So we'll talk about that calcium phosphate factor, or not factor, I guess the multiplying. You actually multiply the levels together, and if you get above a certain level, you're more likely to precipitate out. We'll talk more about that later, but essentially you worry about precipitating. You can get embolus that can occur from that. You can have tissue depositions of this calcium phosphate out in the tissues, and that's no good. So one other thing to consider is that when you have your blood going through a dialyzer, what do you worry about it doing while it's outside of the body? Clotting off, right? So anytime your blood's in contact with foreign tissues, you're probably going to want to try to clot off, right? So in order to avoid that, we actually will, and we know calcium is a really important cofactor for kicking off the clotting cascade. So one of the things that they'll put into the dialysate fluid is actually called citrate. They'll put in citrate, and they'll actually bind up calcium and prevent the blood from clotting off in the dialysate, or in the dialyzer. When that blood goes back into the patient, they're usually hypercalcemic. So that can be one thing you may actually need to go ahead and replace their calcium in order to help make sure they don't get hypocalcemic and have all the problems associated with that. Okay, so any questions about acute kidney injury?
We avoid calcium or we don't avoid calcium?
So it depends.
Okay.
the best answer, right? So again, if they get hypocalcemic because you're pulling it all off of that citrate anticoagulant, then you need to replace it, right?
Okay.
But if you are having patients who have really high phosphate levels, you want to avoid giving extra calcium, especially if their calcium levels are normal, right? Or if you're looking at their ionized calcium, which is kind of a better idea of what the active amount of calcium they have is. So you avoid giving that. So there's like a factor that we'll do. So we'll multiply, calcium and phosphate together. If it's above 55, then typically you don't want to give any more calcium because we're about it crystallizing out. Yep. There's more of an issue with chronic kidney disease patients than the acute kidney injury patients. But if you see like crush or burn injury where you have a lot of lysis to a lot of those cells, that's where you can run into problems. Okay, so chronic kidney disease is usually going to be staged out based on how far down their GFR has been diminished. You can see like stage 1. I guess technically we're all at stage 1 chronic kidney disease. You had a disease and didn't even know about it. But as you get lower and lower, you can see here, stage 4 is around 15 to 29 mLs per minute, whereas stage 5 or end-stage renal disease is less than 15. So that would be considered just kidney failure, right? So looking at some of the complications that we can run into, lots of issues pop up because of chronic kidney disease. These are some of the sicker patients that you're going to see, especially when they come into things like the ICU, if they get infections, things like that. They're very difficult to manage because they have all these extra complications. Although I'm pretty sure when the nuclear bombs drop, you will find cockroaches left and dialysis patients. For whatever reason, you cannot kill them. They'll be sick as snot, but they will not succumb to it for whatever reason. So I think they're Highlanders, maybe. I'm not sure, but anyway, they stick around for a while. Yep, I know there can only be one. Okay, but just kidding. Okay. So looking at issues where you have chronic kidney disease, you have kind of high levels of uric acid around. You have this uremia. It's kind of long-standing. You end up having more risk for bleeding. So this bleeding diathesis. They can have impaired, basically some mild degree of immunosuppression that can happen from this, and a lot of platelet dysfunction, right? So they're just more likely to bleed. Immune systems are not really kind of working as well as they should. More risk for infections, okay? As far as endocrine goes, they're more likely to see hypoglycemia because, as we remember from the endocrine section, is that insulin gets partially eliminated through the kidneys. If it's not getting eliminated there, it sticks around for longer, has longer half-life, more likely to see hypoglycemia from that standpoint. Okay. GI effects, you can see things like delayed gastric emptying, GI bleeds, again, really back to that bleeding, coagulation dysfunction, and you see a lot of nausea, vomiting, anorexia, mostly related back to that uremia. So you can have issues where their nutrition is not going to be real good. They can have wasting it's occurring because, again, they just don't feel like eating. And then neurologic complications, you can see things like uremic encephalopathy, peripheral neuropathies. So lots of problems we're going to run into based on these patients not having good kidney function. So what are some things that can cause chronic kidney disease? Diabetes type 2 specifically is probably going to be one of the leading causes of this, just causing that kind of nephropathy, just having constant high levels of glucose, just kind of shredding that glomerulus, just leading to further damage. But that can be compounded by things like hypertension. Glomerulonephritis can do this as well. And other things that will be kind of risk factors for developing CKD include diabetes, hypertension, smoking, obesity, and then proteinuria previously would also predispose you to this. So we know that the kidney damage is happening through several different pathways, and so as they get more progressive, you're going to notice kind of a common theme here where they're going to have basically loss of the nephron mass. So the nephron mass starts to degrade. You're going to have this glomerular capillary hypertension that's happening there, and then this proteinuria. Okay, so those are all kind of things you're going to see as all these patients get kind of more progressive. So you notice how a lot of this stuff is going to be kind of more cyclic as things are kind of causing a positive feedback loop where one thing kind of begets another. So for instance, if you're having something like your initial pathogenic injury, let's say you have kind of long-standing type 2 diabetes, you have this glomerular injury, it's happening here, you're going to have a reduced filtration area basically. Okay, so glomerulus, you don't have as many that are working as well, you have reduced filtration. So what does your body want to do if it's not filtering enough through the kidneys? We already talked about some of this. What gets upregulated when you have poor kidney flow? So the renin-angiotensin system, your sympathetic nervous systems, all those things, right? So we're trying to increase glomerular blood flow by doing that, increases pressure. Increasing the pressure is going to do what? Further damage, right? So then you have further damage, you're having more upregulation of these compensatory mechanisms. And so this is where you start to see things like the proteinuria start to happen here, and these microthrombi. So all these things leading to further and further glomerulosclerosis is happening here, and just further progressive the kidney disease. Again, all of that leading to further compensatory countermeasures And so you can notice how this is kind of just kind of a nasty cycle. Is going to keep getting worse, not better.
Okay, so with the anemia of chronic kidney disease, some of the big components of this are going to be, one, you have a decreased production of erythropoietin. Normally those are, that is produced within the kidneys itself, so about 90% of that production occurs in those interstitial fibroblasts. Once that's gone, you don't have as much stimulation to produce new red blood cells and hemoglobin, so you end up with this normochromic, normocytic anemia that happens there. The other big component of this is the fact that you have some degree of iron deficiency. So for instance, because you have decreased GI uptake, that can be one issue where even if they are getting enough iron in their diet, they may not be having enough actually being absorbed. Other issues that can come about with their frequent lab tests. They have a lot of lab draws. You can actually see an appreciable decrease in the hemoglobin concentration. And then also with patients on renal replacement therapy, things like hemodialysis, there is some blood loss associated with that because not everything is recovered from the dialysis circuit itself. So you end up having some blood loss over time, especially if they're getting it chronically, say every Monday, Wednesday, Friday. That can be one reason for that. And then the main reason why you're going to see that your erythropoiesis stimulating agents do not work that well is normally going to be due to a deficiency of iron. So iron is vitally important here. We have to replace that in good amounts to make sure that they can make the hemoglobin and make the new red blood cells that they need. Moving on to chronic kidney disease related mineral and bone disorders. Again, this is very common in patients with CKD, mainly because they have lots of derangements and levels of things like parathyroid hormone, things like calcium and phosphorus. Normally, when you end up having decreases in calcium and specifically calcium and also in vitamin D, that's going to lead to higher PTH levels, which is going to lead to more bone resorption and osteoclast activity. We know that vitamin D also gets activated, at least the final activation step to calcitriol happens within the kidneys. So if you don't have that around, that's also going to lead to higher PTH levels. All right. Anytime calcium and phosphorus meet, they tend to precipitate, and so we talk about this calcium phosphate product as one of the things that we'll monitor for in our patients with CKD, usually around level 55 or so. So if you multiply your calcium level by your phosphorus and you end up getting something greater than 55, that is kind of indicative that you're going to be more at risk for developing some of these calcifications that can occur that can deposit into the tissues. But basically, you're going to have more bone turnover, you're going to have these soft tissue calcifications, and all of this kind of culminates in what we term as renal osteodystrophy, which we'll kind of go over in more detail in the next slide.
Thank you. So again, when we have decreased renal function, you're going to not be able to, basically you end up seeing increased phosphate levels, right? Because you're not able to filter out quite as much. That phosphate can end up binding up your calcium. So like I said, that if you ever get a chance to, if you have a vial of calcium phosphate and something like calcium gluconate or calcium chloride, and then think of like potassium phosphate, if you ever mix the two together, it's really cool to see all the precipitation. So not a good use of drug resources, but if you get a chance, try it out. Anywho, though, so you're going to have a relative decrease in calcium. So lower calcium levels, what does your body want to do? How does your body respond to that? Yeah, take it out of the bone. And it does that by? Yeah, PTH. So we're going to upregulate PTH, and that's going to help to start to increase that osteoclast activity. So it starts to increase bone turnover at that point, right? So if increased PTH, that increased calcium and phosphate reabsorption is also going to be occurring. So it's going to help the kidneys to reabsorb more of that calcium and phosphate. Hopefully, try to get more calcium coming in through the GI tract as well. Okay, but the big thing we worry about is that bone, that calcium mobilization from the bone itself, and then also having low vitamin D levels. Right, you're going to see increased amounts of PTH as well. Okay, so the PTH parathyroids are responding both to calcium and low levels of vitamin D in these cases. So again, this is another one that is kind of a cyclic kind of nature here, but again, just to kind of briefly walk through it. You have this progressive kidney disease, you're going to have impaired phosphate excretion, so you're going to be retaining more phosphate. So this is going to be really important. Some of the drugs we're going to use are going to be involved in trying to bind up phosphate and preventing it from being absorbed. But basically, you see more this calcium phosphate product, you're going to have more calcification in the tissues. Okay, maybe one thing you run into. Also here, you're going to have decreased production of that 125 dihydroxy vitamin D. Do you guys remember what the name for that is? Calcitriol, yep, so that's the activated form. So if you have that, you're going to have decreased intestinal absorption of calcium and phosphorus. You're going to decreased or impaired bone mineralization here, which is going to lead to osteomalacia, which we talked about. So, and again, this is going to lead to increased PTH secretion, which again is going to lead to further bone turnover. And so you see how this kind of sick cycle happens, where any of the calcium you're liberating from the bone gets bound up by phosphate, and that's just going to worsen the cycle there. So a lot of the drugs we're going to use are trying to kind of interrupt that cycle and hopefully keep the bones as strong as we can. Okay, so again, you see this parathyroid hyperplasia just related to basically lack of this vitamin D and this calcium, but that also ends up making it more resistant as the tissue gets more hypertrophied. And so you end up getting this osteitis, fibrosis cystica, or basically this high bone turnover disease that occurs here. That can also affect erythropoiesis as well, because again, the marrow is now being affected and lead to osteomalacia. So all kinds of bad things occurring from this standpoint. So some of the things you might see with a patient with chronic kidney disease, obviously if they're having the uremic symptoms are going to be just kind of looking real puny, just kind of fatigue, weakness, shortness of breath. You may be seeing things like weight gain related to fluid overload, things like that, and peripheral neuropathies can start to develop as well. And then obviously looking at things like changing urine output can help you kind of guide to see whether or not this is a new change for them. Foaming of the urine, which is a good sign of proteinuria, and abdominal distension as well, just so they maintain or kind of hold on to more fluid. But, so what do we want to do for these patients? Hopefully we want to either delay or prevent progression of disease. Can I fix chronic kidney disease? Not unless we give them new kidneys, right? So we don't want to do that. So we want to hopefully prevent or delay progression of any more disease. Hopefully minimize some of those complications we were mentioning previously. And then the big thing we want to do is limit the need for either hemodialysis, peritoneal dialysis, or transplant. So the longer we can keep them off of that, the better, because again, those are not therapies that are without risk. You worry about things like infection and other problems that come about from that, so we like to hold off on that as much as we can. And then obviously you want to address the primary cause, so either the diabetes, the hypertension, or the glomerulonephritis, whatever happened to be cause CKD, we like to prevent that, or at least treat that if we can. So just because I thought this was a good picture to kind of show you the difference between hemodialysis and peritoneal dialysis. So basically, hemodialysis, we're taking the blood outside of the body. Usually about 4 hours, 3 times a week, we're going to take the blood out. It's going to go to the dialyzer. Here's the actual dialyzer itself, where it filters out all the waste products, and we stick it back in the patient. Okay. A lot of your long-standing patients will have a fistula being put in there that allows for easier access for the dialyzers, right? Otherwise, you can end up putting a dialysis catheter in for if you need like a short-term use for it. So for instance, if I had a patient I needed to dialyze for aspirin toxicity, we just kind of put a short-term dialysis catheter, usually in right around the femoral site. I'm trying to think anywhere else they will put them in. That's usually the main one they try to go for, but. Anywho, that would be the hemodialysis, where you're pulling the blood out of the patient, and there's also peritoneal dialysis. You guys have any experience with this? Basically, you're putting a dialysate solution, you're putting it into the patient's peritoneal space, where they have passive diffusion of waste and things like that, and then you'll basically pull it out. So you put dialysis fluid in, and then you pull urine out, basically. Okay. So again, you can have exchanges. You leave it in there for a period of time, either 20, 30 minutes, maybe an hour, and you'll have to do that several times in order to help clear out the blood. And so this is less invasive for the most part. Patients don't have to necessarily go to the dialysis center like they do for peritoneal dialysis, so there could be some benefits to using that for some patients. Big thing we worry about here, though, is we end up getting peritonitis. That's what I oftentimes see a lot of our chronic kidney disease patients coming in for, who are on peritoneal dialysis. They get infected, and then we can actually end up giving peritoneal antibiotics actually in their dialysate solutions. That might be one thing you see out there. That makes sense? One's much more of a passive process happening inside the body versus the hemodialysis being done as an active process outside the body. So anyway, so one of the things we can do as far as non-pharmacologic therapy goes, as far as diet goes, you want to try to limit protein intake as best you can, usually less than 0.8 grams per kilo per day if their GFR is less than 30 mLs a minute. Okay, and again, protein is going to be high in what? That we're worried about with our CKD patients? What electrolyte? Phosphate, right? It's going to be high in phosphate, so you want to limit phosphate intake. So that's where limiting protein can be useful for this. Also helps limit some of that proteinuria as well. And then hopefully limit their sodium intake. Less than 2 grams a day would be another recommendation. And then hopefully get them smoking less and hopefully exercising somewhat. If you're looking at patients with diabetes with chronic kidney disease, there's certain medications they absolutely should be on, and that will be an ACE inhibitor, because we know that those are nephroprotective, absolutely. So this can help to prevent this kind of more progression of the disease itself. So they really should be one on these to help prevent further progression. Okay. Some of the things you have to worry about when using an ACE inhibitor or an ARB with your chronic kidney disease patients, what can it do to the kidney function in the short term? Yeah, so you can have a transient decrease in kidney function, right, because it's going to cause dilation of that efferent arteriole, and so you can see an acute hit in their renal function, right? So that's why you want to start low dose and kind of titrate up. The other thing you worry about is what electrolyte does the ACE inhibitors affect? The potassium, right? So you want to make sure the potassium's not getting too high because they could already have kind of pre-existing hyperkalemia anyway. Okay, so that's one thing you want to be careful of as well. So watch out for that. Other thing is metformin. If they're on metformin, if they have a creatinine clearance less than 30, you want to go ahead and get them off of that. Okay, because then you worry about the lactic acidosis that can develop. They used to recommend it based on serum creatinine levels. They don't really do that anymore. It's just based on their GFR. Okay. As far as hypertension goes, usually the target blood pressure should be less than 140/90. You end up seeing significant, if they're having a lot of albumin excretion, a lot of proteinuria in the urine, then you may shoot for even a little bit lower blood pressure mark. So like 130/80 might be better for them. Again, if the patient has diabetes, ACE inhibitors are going to be best for them. You may find that things like diuretics, like your thiazides, are really not going to be as effective for these patients, especially as they get poor, more restricted kidney function. Things like thiazides might not be super useful, so you may need to use more like beta blockers or clonidine or other drugs like that with different mechanisms. But again, manage their other disease states and let that guide your hypertension management, right? So if they have CHF, what type of antihypertensives should they be on? They probably should still be on ACE inhibitor as well, right? Because it helps prevent that left ventricular remodeling, things like that. They have a previous history MI they should be on. Probably like an ACE and like a beta blocker, right? Probably should review these things at some point. It's good information to have. So anyway, so remember, they still have other compelling reasons for certain medications for other disease states. This is just going to help supplement their hypertension management for their CKD. So, as far as anemia goes, you need to make sure they have enough oxygen carrying capacity in the blood to oxygenate appropriately. You're going to find that we like to decrease their signs and symptoms of anemia, and then also hopefully decrease their need for transfusion. So a lot of cases, especially if they are not on appropriate therapy to fix their anemia, they have to end up getting a lot of transfusions, which has its own risk associated with it. So what we do are we're going to use these erythropoiesis stimulating agents, or ESAs, and we're going to give them iron supplementation. Okay. Usually we're going to use the hemoglobin as our monitoring parameter here. So, so how high should you shoot to get their hemoglobin? Like, what's a normal hemoglobin for a patient? 12 or 13. A little bit higher than that for some patients, maybe 14, 16, something like that. So, we don't want to shoot for normal hemoglobin, right? Because these are not necessarily normal patients. You want to shoot for a little bit lower, because what we find is if you increase their hemoglobin too high, say like above 13 grams per deciliter, you end up running into increased mortality. So things like increased risk for stroke and cardiovascular disease. So don't want to do that. Okay. So basically, if your patient's hemoglobin is less than 9, that's when you start to consider using one of these erythropoiesis stimulating agents, right? So, and basically you want to go ahead and discontinue it when it gets above 10, or in patients with renal replacement therapy if it's above 11. I think it's a little bit higher for our RT patients. They're losing more blood anyway, right? Because we're pulling a lot of it off. 3 times a week they're having to go to the dialysis center. They're going to be losing more hemoglobin anyway, so you shoot for a little bit higher range for them. Okay, but again, the hemoglobin may still be decreasing for your patient, even though you're giving them these erythropoiesis stimulating agents, if their iron is not set correctly, right? So you need to make sure they're being supplemented with iron appropriately in order to make sure your ESAs are going to work. And the ESAs are expensive drugs, so you want to make sure that you're doing the easiest things in order to make sure that they're going to be successful. So the most common erythropoiesis stimulating agents we have are going to be epoetin alpha. A couple of brand names you might see are Epogen or Procrit, and you have darbepoetin or Aranesp. Those are the most common ones we see being used. Again, black box warnings for anytime you're increasing the amount of erythropoiesis you have, you're going to have increased risk for things like MI, stroke, VTE. Why do you think that is? So think about the blood's going to get kind of more sludgy as you start to increase the hemoglobin concentration. The blood typically gets a little bit more viscous, and that's where you can start to see occlusions start to occur. So you worry about things like the MI, stroke, all causes for death that can occur from that. So that's why we tried not to shoot to get the hemoglobin too high. And if you think about it, you know, if you have, like, say, someone who's going to ride in the Tour de France and they were blood doping, what did they end up usually dropping dead from? Usually have like a stroke, right? Because they are dehydrated from riding their bikes, and then they also have just a super high level of hemoglobin. So there's lots of stories out there of people dying from blood doping due specifically to that. So obviously this would not be that severe in this case. I don't know of any CKD patients who are in the Tour de France, but just keep that in mind. Same thought process. So you may see patients be on these drugs several times a week. Sometimes, like especially with ARNS, we can get away with using the drug like every 4 weeks in some cases. So that can be more useful for your patients. These have to be injected because again, they're protein-based products because they're basically replacing the erythropoietin that your patient is not making on their own. So think about that. Obviously, adverse effects include things like hypertension, and then that vascular access thrombosis can also be a risk as well, just due to that increased blood viscosity. So looking at their iron status, so you need to, this is probably going to be required by all patients who are receiving an ESA, so you might as well just go ahead and prescribe both concomitantly. You need to make sure they're also getting adequate intake of things like B12 and folate, which can be diminished by patients who are on kind of chronic renal replacement therapy. So make sure you're kind of getting their multivitamin, make sure you're getting enough iron in their diet and through exogenous supplementation. You may find that oral intake of iron is not going to be enough for some patients, so especially because the bioavailability is pretty poor for that, especially if you have any kind of drug interactions where they're being bound up. So a lot of cases you may need IV replacement in some cases. The most common oral preparations you're going to run into, things like ferrous sulfate, ferrous gluconate, ferrous fumarate. Again, when you're dosing these, don't dose them based on the actual milligram amount that the pills are or the liquid is, based on the elemental iron content. Okay, so when you see dosing recommendations for iron, look at the elemental content that's recommended for your patient, and make sure you're dosing the actual pills or tablets by the elemental content. So, for instance, ferrous sulfate is only roughly 20% actual 20% actual elemental iron. So if you look at a 365 tablet, or I'm sorry, 325 tablet of ferrous sulfate, only about 65 milligrams of that is going to be actual elemental iron. Okay, so a lot of the packaging is starting to read elemental iron nowadays, which is better because it leads to less kind of dosing confusions, because otherwise you may over or underdose your patient if you're kind of looking at it incorrectly. So be aware of that. And then there's IV iron preparations as well. So there's things like iron dextran. I think probably the most common one I see now is either iron sucrose or probably the sodium ferric gluconate, so your Venofer or Ferrolicet. Again, this you know, the bioavailability is 100% for that one because you're giving it IV, so that can be very, very effective in raising up their iron levels and allow the ESAs to work better. Obviously, there's lots of side effects associated with giving iron. So the biggest one you worry about? Constipation, right? What does it turn the stools? Blacken, right? So now you have blackened stools, and we said these patients are already at risk for what? GI bleeds, right? And what does GI bleed look like? Black stool, right? So again, education is really important because again, if they see that, it may be kind of a warning sign for other things, or it could just be their iron. So be aware of that. And very common to see a lot of abdominal cramping and nausea, vomiting. So just be aware that some patients may not be able to tolerate oral therapy, which is why they may need to use IV. You do run the risk of some allergic reactions to some of these iron products, not to the iron itself, but it's usually to whatever it's compounded with. And so you need to do slower infusions because you run the risk of seeing things like hypotension, dizziness, and headaches. Okay? So it's probably the most common side effects you're going to run into with these iron products. Okay. Again, if you can use oral therapy, this is going to be better because they're typically cheaper, fewer side effects, at least really concerning ones that you're worried about with the IV products. But for patients who are on renal replacement therapy, most often they're going to need IV therapy, IV iron anyway, just to really get their stores built up so their ESAs can work a little bit better. Got to monitor your iron at least every 3 months while they're on ESA therapy to make sure they have adequate levels. And then if you're titrating anything, then maybe monthly to make sure they have adequate stores there. But so any questions on that specifically? So again, they're on ESA, they probably need to be on some type of iron supplementation. IV is going to be more preferred for RRT patients just to make sure that they can have those adequate stores because they're going to be losing more blood anyway. Okay, I think I'm going to go ahead and cut it there. give you guys a little bit of a break before spring break, right? You guys get a whole week without me. Exciting. Don't do anything that I wouldn't do because it's not a lot. So have fun. And refer back to your STD lecture just in case anything. You have any friends that have a little too much fun. Okay.